Good morning, ladies and gentlemen. I'm Xiong Cui, come from Tongji Hospital, Huazhou University of Science and Technology. The title of my presentation is Extravascular Contrast Enhanced Ultrasound in Disease of the Digestive System. This presentation is also contributed by Dr. Igni and Professor Dietrich. Today I will introduce our studies on extravascular contrast enhanced ultrasound. Extravascular means we do not inject the contrast agents into blood system. The first method is we mix the sonovu with saline and inject them into the biliary system or abscess cavity. The second method is that we mix the sonovu with water and ask the patient to swallow the contrast agent to show the esophagus and the stomach. The first application is ultrasound-guided puncture and drainage of abscess. Several years ago, we published some case reports on the website of IFOM, and it was cited by the IFOM guidelines on interventional ultrasound. In a study, we enrolled 44 patients who underwent ultrasound-guided needle insertion or catheter drainage. Of them, 39 patients had a solitary abscess, and 5 patients had 2 or more abscesses. To make the contrast agents, we take 0.1 milliliter of sonovu in 20 milliliter physiological saline. This is the video how we make the contrast agents. Usually we just take few drops of sonovu. Firstly, we perform the intravascular contrast enhanced ultrasound to show the structure of the liver abscess. And then we inserted a needle into the abscess. For the complex multiple abscess, we injected contrast agents into the abscess to confirm if there are communication between cavities. For example, this is a complex liver abscess. It has several cavities, and here we can see there's communication between the cavities. But if the cavities of the abscess did not communicate, a new catheter was also placed. On the next day, we performed the conventional ultrasound and extravascular contrast enhanced ultrasound to assess the complications. Results: we performed 5 needle aspirations in 4 patients and 42 percutaneous drainages in 41 patients. Extravascular contrast enhanced ultrasound show the communication of cavities in 7 complex abscesses and no communication in 1 patient who received 2 drainages at last. This patient had a complex liver abscess, and the abscess had several cavities. Extravascular contrast enhanced ultrasound showed the communication between the cavities, so only 1 drainage was performed for this patient. This is another patient. He had a complex abscess with 2 cavities. Here was 1 and here was 1. After we injected the contrast agent in this cavity, but this cavity was not enhanced, so there was no communication between cavities. And at last, we performed 2 drainages for this patient. This patient had 3 cavities, 1, 2, 3. Extravascular contrast enhanced ultrasound showed there was no communication between them. So we performed the catheter placement for this cavity and puncture without the catheter placement for these two lesions. On the next day, we will check the complications, and we found the catheter dislodgement in 2 patients and pleural injury in 1 patient. For example, in this patient, after we injected the contrast agents in the catheter, we didn't see the enhancement of the abscess, but we saw the enhancement of the surrounding space of liver. So the catheter dislodgement was diagnosed. And in this patient, we also see the enhancement of the pleural space. So there was a pleural injury. This was an abscess around the appendix. The extravascular contrast enhanced ultrasound could clearly show the extent and the shape of the abscess. This was an abscess next to the colon. Conventional contrast enhanced ultrasound showed the wall of the abscess was incomplete. So we did a drainage and inject the contrast agents in the cavity and found that the contrast agents entered into the colon. So we diagnosed this as a chronic diverticulum abscess. Conclusions for abscess drainage. Extravascular contrast enhanced ultrasound is an additional method to get the catheter placement or needle insertion, to examine the communication of abscess or cavities, to assess the catheter dislodgement, and to evaluate the extent of the abscess. The second application is percutaneous transhepatic cholangiography and drainage. In this study, we enrolled 38 patients who underwent PTCD due to primary or secondary bile duct obstruction. We used the same method to make the contrast agents as we introduced in the abscess drainage. Saladinger technique was used to perform PTCD. After a needle or catheter was inserted into the bile duct, we injected contrast agents to show the bile duct. And we also performed X-ray and with X-ray contrast agents to see the bile duct and to see the gateware. X-ray could see the position of the catheter, and the extravascular contrast enhanced ultrasound could also show the position of the catheter. Here we can see the catheter was in the common bile duct. This table showed the causes of the obstruction in the 38 patients in this study, and the most common reasons were ductal adenocarcinoma of the pancreas, common bile duct stone, and clustering tumor. Extravascular contrast enhanced ultrasound could correctly confirm the insertion of the puncture needle and the placement of a catheter. Here is a 3D ultrasound image. We can clearly see the structure of the bile duct. Extravascular contrast enhanced ultrasound could also assess the site and the degree of the obstruction. This picture shows a complete biliary obstruction because of a clustering tumor, and this is the 3D image. This image shows the incomplete biliary obstruction because we saw contrast agents in the intestinal. There is a limitation of extravascular contrast enhanced ultrasound. On X-ray, we could clearly see the position of the gateway, but on ultrasound, we could not clearly see the position of the gateway tip. Complications. Hematoma was found in one patient. Complications. We found a catheter dislodgement in one patient. We performed the PTCD for this patient, but the next day we insert the contrast agents in the catheter. The surrounding space of the liver was enhanced, so the catheter was not in the bile ducts. And we re-performed the PTCD and extravascular contrast enhanced ultrasound. The bile duct it could be clearly seen. And we also found a fistula between the bile duct and the surrounding space of the liver. Conclusions. Extravascular contrast enhanced ultrasound is a new tool for imaging the biliary system. It can confirm whether the needle and the catheter have been inserted in the bile ducts, determine the site and the degree of obstruction, determine the cause of obstruction in some patients, and assess complications after PTCD. In another study, we used the swallow contrast enhanced ultrasound to diagnose Zenker's diverticulum, and we published this paper in Ultrasound in Medicine and Biology. Zenker diverticulum is a lesion of the esophagus because it's near the thyroid, so sometimes it may be misdiagnosed as a lesion of thyroid and results in an unnecessary biopsy. We usually use barium esophagogram to diagnose Zenker diverticulum, but it exposes the patient to radiation. For swallow contrast enhanced ultrasound, we took 2 to 4 drops of sonovil into a cup of water. This video shows how we make the contrast agent. Fourthly, beam ultrasound is performed to show the suspect lesion where the patient in an upright or sitting position. Then the contrast spacing mode was activated. Then the patient was asked to swallow the contrast agent, and the arrival of the contrast agents was imaged. The persistence of ultrasound contrast agents in the diverticulum was monitored for at least 3 minutes. In this study, we enrolled 10 patients. All patients underwent the barium esophagogram in the Department of Radiology at last. Results: while the patient swallowed extravascular contrast agents could clearly demonstrate the contrast agents was transported from the pharynx to the esophagus, and the Zenker diverticulum was shown as a pouch-shaped structure that retained the contrast agents for more than 3 minutes. These patients had a lesion near the thyroid. After the swallow of contrast agents, we can see a pot-shaped structure. Here we can see, and it retains the contrast agents for more than 3 minutes. Barium esophagogram confirmed the diagnosis of Zenker diverticulum. This is another patient. He had a lesion near the thyroid. After the swallow of contrast agents, we perform the 3D contrast enhanced ultrasound. We clearly show the shape of a diverticulum and the esophagus, and the barium or esophagram confirm the diagnosis of a central diverticulum. In this study, we also had 10 healthy volunteers as the control group. After the swallow of contrast agents, we could see nothing in the esophagus, but we can find the contrast agents in the stomach. Therefore, we may find some lesions in the stomach. For example, this patient had a tumor in the stomach. Limitations of a swallow contrast enhanced ultrasound. It cannot image the middle part of the esophagus because of the air in the lung. And all lesions of a central diverticulum in our study could be detected on conventional ultrasound before swallow contrast enhanced ultrasound. So we can only suggest swallow contrast enhanced ultrasound as a method for confirming the diagnosis of a single diverticulum, but not as a replacement for barium safety of extravascular contrast enhanced ultrasound. In the new Wolfram guidelines of contrast enhanced ultrasound in the liver, it says that intracavitary use of contrast agents is safe. Thank you very much for your attention.